Hello everyone. In this session, I have planned to start a lecture series for the previous year questions of obstetric and gynecology. So all the previous year questions asked in various competitive exams taking place throughout the country. So these lectures would be beneficial mainly for the PDCET students and also for the students who are preparing for NEET PG exams. So you can subscribe this channel for more such videos, and I will try to post daily or alternate day the videos with few questions which have been asked in the previous year competitive exams from obstetric and gynecology. So the first question is hormone responsible for decidual reaction and Aries stellar reaction in ectopic pregnancy is. So out of this 4 question you have to choose the correct answer. So this question has been asked many times. Hormone responsible for decidual reaction and Aries stellar reaction in ectopic pregnancy is progesterone. So Aries stellar reaction, adenomatous changes in endometrial glands, hyperchromatic nucleus, vacuolated cytoplasm is seen. It is seen in ectopic pregnancy in about 15% cases, and it indicates lightening of conceptus. So just remember that all of these points are also important, and indirect questions from the previous year can be asked in from these points also. Next is main contributor of amniotic fluid in second trimester is maternal plasma, fetal skin, fetal urine, or none of the above. So question is about the major contribution of amniotic fluid in the second trimester of pregnancy. So the answer is fetal skin, and this table is important. In the early weeks of pregnancy, maternal plasma is the main contributor of amniotic fluid. In the second trimester, it's fetal skin, and beyond 20 weeks, it's fetal urine. Next is urine production begins by 5 weeks, 8 weeks, 12 weeks, and 20 weeks. Before skipping to the next slide, all of you should try to guess the answer. So urine production begins by 12 weeks. So this is also important. These tables are important, showing some events and times of gestation. So genital ridge formation starts at 5 weeks. Gonads, testes at 7 weeks. Ovaries are formed at 8 weeks. Sex identifies on USG by 14 weeks, and urine production begins by 12 weeks. Next question is parameters which remains unchanged during pregnancy are all except. So in exams always be aware of this thing, all except, none of the above, all such things. Okay, so which are the parameters which remains unchanged during pregnancy? Inspiratory reserve volume, maximum breathing capacity, vital capacity, or expiratory reserve volume. Which of the following is changing? So the answer is expiratory reserve volume. Another important table. So parameters which increases during pregnancy, tidal volume and inspiratory capacity. Parameters which decreases during pregnancy, residual volume, expiratory reserve volume and functional residual capacity. And parameters which remains unchanged, respiratory rate, inspiratory reserve volume, vital capacity, and maximum breathing capacity. So this table is also important one. Next question, choose a false statement related to the uterus. False statement: capacity of non-pregnant uterus is 50 ml, weight of pregnant uterus is 1100 grams, length of pregnant uterus is 35 centimeter, length of non-pregnant uterus is 7.5 centimeter. So database questions are also frequently asked. So the answer is that capacity of non-pregnant uterus is 50 ml. This is false statement because capacity of non-pregnant uterus is 10 ml and capacity of pregnant uterus is 5000 ml. So the other 3 options are correct. So also try to remember these: weight of pregnant uterus 1100 gram, length of pregnant uterus 35, and non-pregnant uterus is 7.5 centimeter. Next is most common complication of anencephaly during labor is postpartum hemorrhage, pseudo shoulder dystocia, retained placenta, or inversion of uterus. So answer is pseudo shoulder dystocia. So this one is also important, has been asked previously in some of the exams. Next is which of the following is not true about nuchal translucency? Another question with not true. So about nuchal translucency measured between 11 to 13 weeks, up to 3 mm is considered normal. Best approach for measuring NT is transabdominal, and most powerful USG marker for aneuploidy is in first trimester. So answer is C, that is best approach for measuring NT is transabdominal. It is not transabdominal, it is transvaginal. So this was false and other 3 options are true. So you can remember in this way that true for nuchal translucency, it's measured between 11 to 13 weeks, up to 3 mm is normal. Best approach is not transabdominal, it is transvaginal, and most powerful USG marker is for aneuploidy in first trimester of pregnancy. Okay, Next question, most significant finding in CTG for detection of fetal hypoxia: early deceleration, variable deceleration, late deceleration, or sinusoidal deceleration. So answer is C, that is late deceleration. So this table is important for CTG. Type of deceleration, description about that, and cause of treatment. So early deceleration is type 1 DIPS. Deceleration begins and ends with uterine contractions due to fetal, and why it happens. Early deceleration is due, this is usually asked, that early deceleration is due to fetal head compression and vaginal activation, and no treatment is required. Late deceleration, also known as type 2 DIPS. Deceleration begins after uterine contraction and persists until after contraction is finished. And what does it indicate? Late deceleration indicates fetal hypoxia and chronic uteroplacental insufficiency. If late deceleration are recurrent, immediate delivery is necessary. So this is the importance of late deceleration. Third is variable deceleration, inconsistent in onset, duration, and degree of deceleration that disappears with change in position of the patient. And why it happens? It happens due to umbilical cord compression with change of mother's position, and deceleration disappears. So early deceleration, fetal head compression; late deceleration due to fetal hypoxia or chronic uteroplacental insufficiency; and variable deceleration is due to umbilical cord compression. So remember this table, these points are important. They usually ask what is the cause for these types of decelerations. Next is Caldwell and Mohe classification is used for. Scientist based name question are also asked frequently. So Caldwell and Mohe classification is used for type of pelvis. Okay, so type of pelvis is the correct answer. So in short about Caldwell and Moye classification for type of pelvis: gynecoid they divided the type of pelvis into gynecoid 50% cases, anthropoid 25%, android 20%, and platyploid 5%. So question can be formed in this way also, that which of the following is included in the type of pelvis in Caldwell and Moye classification. So these four you have to remember. Next and last question for this lecture is: dystocia dystrophica syndrome is seen in. Dystocia named syndromes are also important. Dystocia dystrophica syndrome is seen in anthropoid pelvis, gynecoid pelvis, platyploid pelvis, or android pelvis. So correct answer is D. You have to just remember, not much of the description is required for such questions. It may come directly. So dystocia dystrophica syndrome is seen in android pelvis. So thank you for your patience, and I hope you would have liked this lecture, and subscribe this channel with this handle at Shishu Care for more videos on obstetric and gynecology previous year questions. Your suggestions are welcome. Thank you very much.